No.
Okay.
Are we ready to
We can
start?
start, Frida. Yes.
Okay, great. Good morning, everyone. Welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on January 10th, 2022.
So moved.
Thank you. Do I have a second?
Second.
Great. I will poll each member individually for their vote. Jose Pagan,
Yes.
Dr. Katz,
Yes.
Sally Hernandez Pinheiro,
Yes.
Barbara Lowe. Is Barbara on?
She's not
Okay.
on the WebEx.
Okay. Dr. Patricia Martone. Also, maybe not on yet. I vote yes, so I think the motion is adopted. We now have a number of action items to consider today. First up is the temporary security staffing resolution. Dr. Wei, if you could please read the resolution into the record and proceed with your presentation.
For the resolution, I guess, can we go to the last slide and I'll read that real quick and then we'll come back to the beginning.
Thank you.
Oh, all the way to the end. Whoever's controlling the slides, can you go to the last slide, please? Okay, so yep, that's it. So the Office of Quality and Safety is seeking approval to award contracts to Universal Protection Services LLC, Johnson Security Bureau, Incorporated Maxi Building Security and Management Corporation, Aaron Security Inc. to provide supplemental security staffing services to the system. 3-year contract with 2 one-year options, exercisable at the discretion of New York City Health and Hospitals, not to exceed $11,600,000. And hoping to be effective May 1st, 2022. So if we can go back to the first slide, I'm joined today by Dr. Shaw Natsui, our Assistant Vice President of Emergency Services, also with Juan Checo, our System Chief Security Officer, as well as Christine Clarity's team, Manny Saez, who contributed to the RFP process here. And so essentially we've been challenged with our hospital police staffing, and that's something that we're working really hard to address. The demand for staffing has also increased with COVID, with additional posts for testing, for vaccination, more entrances, more screening at entrances. And so we were unable to meet that demand and needed to use temporary agency staffing to help with security both at central office and at our facilities. And that's something that we decided to go back to a RFP for because of the dollar value. Need to bring it here to the Finance Committee and to the board. And so I'll turn it over to Shaw, who will take us through the background, the RFP, and why we settled on the vendors listed in the end here. So Shaw.
Great. Good morning, everybody. Thank you, Eric. So to be brief, as Eric mentioned, this is again for supplemental security staffing firms in addition to our core hospital police staffing. And so we are moving from the 2 vendors that I'd used up till now with the estimated annual spend of $2 million to our process, which the following slides describe. I'll kind of move quickly through these slides in the interest of time, but the services provided are generally around security guards, supervisors, and fire safety positions. And the contracts are relatively simple in terms of a cost structure based on the rates. The RFP process, as outlined there, ultimately focused on the top 4 rated applicants, of which we are contracting or proposing to contract with, which Eric already mentioned. The references are also on the next slide, which I won't obviously read off, but two of the firms are ones we are already familiar with positive feedback from the facilities, and the other two had appropriate references as well with similar healthcare settings. The RFP criteria, it's fairly straightforward, but obviously the MWBE was evaluated closely, and all have a strong experience with similarly large health systems. Go to the next slide. In terms of the MWBE, two were as listed, as well as the other two with the 30% utilization plan and diversity status. So those are the four that we are ending with today. At this point, we also wanted to make a brief update and mention around hospital security for the system, acknowledging again that while this contract is for supplemental security, again, including a large component of our T2 sites that will be winding down over the next coming years. In terms of general security, since the incident at the Jacoby ED waiting room in late January, a lot of work and effort has been put forward by offices and individuals across the system and across the facilities, departmental and higher leadership, in speaking with staff and doing debriefs and security assessments and learning from both the incident and the after action report. We're happy to answer more questions about this, but this process has entailed looking both internally as well as externally, both in New York City and other safety net hospitals in other cities, in terms of things that we could do additionally to improve our safety in our hospitals here. A lot of direct actions have already been taken at Jacoby specifically around immediate interventions that could be put into place, such as direct security lines from each phone in the emergency department, as well as visibility mirrors and bulletproof glass. We've convened a large working group centrally to focus on pilots involving metal detectors, armed paid detail from NYPD, as well as taking a closer look at hospital police recruitment and retention and our active shooter training. So wanting to just mention this to this group in the context of security, but obviously we'll continue to focus back on the proposal at hand, but happy to take more questions on this as well. And so finally, the last slide is the contract details and the spend over the course of the period, which is 3-year contract with 2 1-year options, with a total of not to exceed $11.6 million. And you see the breakdown distribution between T2 and non-T2 as well. So at this point, happy to close and any questions.
Frida, are you
Great.
going around?
Great. Thank you. Yes, sorry, I couldn't find my mute button.
Okay.
I'll go around for questions. Jose Pagan?
I was trying to understand like the protocols that are used to deploy security at hospitals, just to get a sense of like how do you do that, given that you're looking at X number of vendors and that will provide those services. Are they armed, for example? Are they deployed based on needs by CEOs?
I could take that one, Eric, unless you.
Yeah.
Go ahead, Charles.
Yep. So generally, most of the supplemental staffing beyond hospital police has been at some of the facilities other than the acutes, and then a couple of the acutes. And generally, so these are all unarmed security presence. They are often used in a role, particularly at the acutes, in what we call watch person role, which is typically front entrance, additional security presence, and things where we just need additional posts that are manned and for whatever reasons, for short staffing, we may need to put in temporarily facilities. For the test and trace facilities, a larger presence of these supplemental security staffing firms, just given the nature of that expansion needed.
Okay, and are there issues connected to language, for example, or ability to communicate in different languages, or how do you handle that part?
That's a great question. So my general understanding would be because they are at the most front end presence at our entrances for the acutes. It's just as with any patient that normally comes in that may need assistance with patient navigation. So, I think they are able to use the facilities, language services, and translators if there's an in-person language. But otherwise, we'd have to use a translation, device or mechanism. But it's just as if any other staff member trying to help a patient navigate through the facilities, of course.
Thank you.
Thank you. Dr. Katz, any comments?
No question.
Sally?
I have a number of questions. I'd like to start first by comparing and contrasting the last contract with this contract. So you have 4 vendors this time, you had 2 last time. What was the reason for increasing the number of vendors?
Yes, so for the 4, the reason we landed on 4 was based on the scoring. There was a clear delineation between the top 4 and the rest. In terms of why expanding from 2 to 4 is largely a component that both that they were all firms that the RFP committee was comfortable with, but also allows us for more flexibility, as we've seen over the past year or two, that the demand for these supplemental security firms is constantly goes higher and higher, and so it gives us an opportunity to be able to have more ability to find the people when we need them most.
And how many security personnel did you have under the last contract? Do you project having, or you did have on the last one? And how many do you project having under this new contract?
How many posts or positions?
Yes.
Juan, do you have if you're on, do you have a sense of the number?
I don't actually have that figure in front of me.
Sally, we have it broken down more by cost. So if we go
Okay,
to the cost,
What was the cost last time and what is it now?
yeah, so pre-COVID, it was right under $2 million a year, but because of the T2 sites and the excess kind of, I think it's the next slide. There it is. Right. So the 1.9 million is kind of what we expect to be the baseline. And then over the years, as we close the HP staffing gap, we'll see that number come down even further, 1.8 and 1.5.
And the measures that the central working group, I guess, recommended, are those incorporated in this contract, or are those additional things that are going to be considered? The metal detectors, the additional NYPD detail? Are those
That is
incorporated?
separate, Sally, separate and distinct from this. But because of feedback that we received on the briefing, just because of the recent Jacoby event, wanted to give kind of a overview of the efforts underway to enhance hospital security. So this is different. This is not the NYPD paid detail. This is not the weapons screening,
Yes.
not the hospital police recruitment and retention or active shooter.
So do you think that there'll be another contract coming forward with some of these, or that's still too early?
Too early to tell. We have a pilot going on at Jacoby in the ED waiting
Right.
room right now, but that's in collaboration with City Hall and the Deputy Mayor Banks team. And so there are some things that the city is thinking about outside of hospitals, specifically schools. So this might be a part of a citywide initiative. But if it does end up just being an H&H initiative, then yeah, we would need to bring a separate RFP and contract to you. But that's too early to tell them.
Okay, and would you know the number of hospital police that we have? I'm just curious. I have no sense at all.
Juan, do you have the latest number? I know it's in the 500.
As 543.
Okay, so that's substantial. All right, thank you.
Just Sally, always remember on any 24-hour service, you have to divide by 5, right? Because it takes 5 FTEs to cover 24 hours, 7-day a week.
I see. All right. It's not a lot then. Okay,
Right.
thank you.
Okay, thank you, Sally. Thank you, Mitch. Moving on to, did Barbara join us? I don't. No,
Ms. Lowe is
Barbara.
not on the line.
Okay, and Dr. Marthone, is she joined?
Yes.
Oh, great. Any questions? Dr. Marthone? Okay. I'll take that as no questions. So I just thank you very much to the team for the presentation, including the update on hospital security. I think it's obviously very front of mind, so we appreciate that update. If there aren't any questions, I'll poll each member for their vote. Dr. Pagan,
Yes.
Dr. Katz,
Yes,
Ali,
Yes,
and Dr. Marthone.
Yes.
Great, and I vote yes, so the motion is adopted. Thank you very much. We'll move to the next one, which is for managed payroll and advanced scheduling services. I believe Ms. Seta is going to read the resolution and lead us into the presentation. Ms. Seta?
Hi.
Hi.
The resolution authorizing the New York City Health and Hospitals Corporation, the system, to execute a 5-year contract with UKG Inc. for managed payroll services with an advanced scheduling application for an amount not to exceed $33,421,438, including a contingency of 10% or $3 million.
So I'll go through the deck, J1 and corporate controller. All right, so this is where we're starting with a very old system. We call it the mainframe. It's over 30 years old. It's called a legacy system, and it's not supported anymore. We have to go to something else. There's a significant investment required and a lot of time to program the system, and we use partially PeopleSoft for other services. Scheduling, we use Clearview. It's only for nursing currently. It's inefficient. There's no friendly layout for customers to use, and functionality and reporting are limited. The future state that we're proposing would look like payroll services would be managed by UKG. The advanced scheduling would be managed by us internally using the UKG software. And down below, you'll see some of the functionality, time and attendance. These are all mobile compatible. People can get this on the mobile device. Real-time punch data. And so it's real time. We don't have real time now. Integrated with scheduling, which I'll talk about in a minute. Employees could request time off. They could look at scheduling. They could swap shifts. They could attest to time off, meal time, etc. The managed payroll services would include all of our payroll requirements on and off cycle, garnishments, all the payroll tax filing and compliance issues, year-end close management, which would include the W-2s, and the employee contact center, which is the call center. We currently get a lot of calls in our call center. They would take that function from us. The advanced scheduling, as I said before, would include, nursing and non-nursing. So this opens up to, greater possibilities that we could use a scheduling system. Also mobile compatible. The employees could identify shifts and swap them. They could identify open shifts and they could ask to work those. And there's a visibility to staffing coverage, obviously in real time, because the punch data is real time. And the integration with Epic, so we get workload data into the system and we can measure that against the scheduling, good for planning, good for reporting, and you can predict what the scheduling would be based on historical census. The data and analytics, there are over 800 reports delivered within UKG's product. Real-time access to all the dashboards, key performance indicators, so we could operate on the fly. We could look at, the different metrics, and of course the ad hoc reporting capabilities. Overview of procurement. We started this process back in September. We issued the RFP. We issued both scheduling and payroll together. This is a lot of synergies working with that. In November, we had demos and evaluations. We had 4 proposals received, 3 of which included both the payroll and scheduling. And in January, the 2 committees looking at scheduling and for payroll both picked UKG. I'll turn this over to Tatiana.
Thank you. So the cost of the vendor contract is split between the implementation cost at 2.5 million and ongoing subscription fees or the annual fees of 7 million a year times 4 years. This is a 5-year contract. And then a 10% contingency is included to account for any unexpected expenditures throughout the period of the contract. So the total 5-year cost is $33.5 million. Our current in-house cost of running payroll is $36.80 per employee per month, which includes both the personnel and non-personnel costs required to manage our 40-year-old payroll system and provide support to our employees and managers. Transitioning to the new system will allow us to bring direct cost of payroll down to $19.50 per employee per month. And in addition, we will be transitioning to a new time capture technology. So we'll be getting actual time, which will allow for accurate capture of time worked. Deloitte Consulting estimated that this technology upgrade may save an additional $15.50 per employee per month to H&H. And next slide, please. Minimum criteria included 10 years in business, MWBE utilization plan, MWBE certification or waiver request, experience with large health systems that operate in a unionized environment, preferably in New York. Selection criteria included functionality, cost, strategy, and timeline approach, and MWB status. Responses were reviewed by 2 committees, as Jay just mentioned, one focusing on managed payroll services, the other on the advanced scheduling solution. And members included cross-functional representation from facility and central office leadership. Next slide, please. UKG formed as a result of a merger between Kronos and Ultimate Software. They're a market leader in human capital management with a large market share in healthcare industry with 3,500 hospital and 10,000 post-acute care clients. Their systems are well known in the healthcare industry and are used in many of the large health systems here in New York City. In addition to the software solution, they can provide experienced, dedicated onshore support that will act as an extension of our payroll team. Corporate social responsibility includes giving programs that are globally inclusive but locally focused, supporting organizations and communities around the globe through donations, matching gifts, and volunteer opportunities. Positive feedback was received from references at Northwell, NYU, and NYP. Out of the 10 vendors that were invited to participate in the RFP, 6 were MWBE vendors. None of the 6 responded to our RFP. UKG's MWBE utilization plan includes subcontracting a portion of the implementation cost to UCI. UKG services can be split into 3 general categories for the purposes of MWBE analysis, implementation, technology, and managed services. The only area where UKG is able to subcontract is the client-side implementation support, which represents roughly 30% of the implementation cost. It includes helping our team extract the data from mainframe and PeopleSoft for all aspects of our data migration, helping with change management, and any process re-engineering the team may want to leverage. The rest of the services are performed by UKG as part of their software as a service model and cannot be subcontracted. Throughout this transition, H&H is committed to supporting the impacted payroll staff and ensuring they are redeployed to alternate position within H&H after system implementation is complete. All impacted staff and their unions were notified of the transition in advance of the RFP being issued this September. There's ongoing training and change management support provided to the staff in the form of regular meetings, status updates, sharing of opportunities, training, as well as job opportunities. Next is the timeline. The new system implementation is expected to take 15 months with a projected go-live date of July 1st, 2023. The implementation will begin with a detailed planning phase, followed by system design, system build, data conversion, testing, and deployment. The payroll system will go live as a big bang, whereas the advanced scheduling will have a multi-phase deployment with nursing going live first. It is expected that the transition of the payroll staff to alternate position outside payroll will take at least 6 months after go live. And that is the resolution that I read.
Great, thank you. I will now go through and ask if there are any questions. Jose, or comments?
No questions, thank you.
Okay, Mitch? You're muted, Mitch.
No questions. I did want to make sure the board understood that we have gotten a huge amount of concern in recent times about payroll from employees because, as Jay has explained, our current mainframe system is just not adequate for dealing with the complexity of a modern payroll, and any mistakes have to be tracked by hand and are extremely time-consuming. We've had a lot of frustration. New York City is an expensive place to live, and when people work an extra shift, they wish to be paid correctly and in a timely way, and our inability to do that is a major problem for our staff. Thank you.
Thank you for that context, Mitch. Sally?
I have a couple of questions. So there's an annual subscription fee. Was that $3 million? I don't remember what it was. The program that's created, this is proprietary. So at the end of the 5-year period, I guess we have to decide whether we want to continue using them and their program or consider something else. Is that how it works then?
Yeah, it's a what they call a SaaS program. Well, it's a cloud service. So it's like Microsoft 365. It's a subscription. When you're finished using it, you basically give it back.
Right.
It is, it's their model. It's their model. They'll manage the payroll. They'll provide the service for us, and they'll do all the compliance. So that's what we're buying them.
this, we have to have one of the oldest payroll systems in any hospital, right? I mean, 40 years sounds very old.
Yes, probably.
Do you know the number of employees that are going to be affected by this? The existing payroll staff that's going to be redeployed?
Yeah, so we have, well, it's a little over 60 employees currently that are employed by us. that
Okay.
would be-
Oh, I know, it was the MWBE. I just had a question about that. So their goal is going to be 3%. Implementation and consultancy, I thought someone said was 30%?
Yeah, it's.
Right,
The implementation is two parts. One is the client side, that's the data conversion, the change management, process reengineering. That's the piece that UKG could contract out. That's 30% of the total implementation. The
okay,
rest of it is provided by their staff because they're going to operate and manage our payroll. They're part of the implementation team setting up the system, so that they don't contract out.
No. Okay, those were my questions. Thank you.
Thank you, Sally. I think Dr. Stone? Okay, I think maybe she's having some connection difficulties. We'll get her question subsequently. I think, sorry, I think that's me. And so thank you, everyone, for the presentation. I think, as Mitch described, this is a huge step forward for managing personnel front to back, scheduling and payroll. And so I think I mentioned this before, when I see IBM mainframe and manual processes, I get a little worried about things. So this is really terrific with the thorough approach you guys have taken. And I think this integrated solution with a single vendor can provide a lot of efficiencies and synergy. I think you mentioned this, but the scheduling is starting with nursing, right? But is the goal to have other functions on the scheduling as well within this time frame? Is that a next step?
Yeah, I think that's the next step, is we're planning for the implementation for scheduling. That has not been decided upon yet, but we have to go through the requirements, we have to see what's involved, and then make that decision.
Okay, so the contract where the cost and things like that we're looking at now would only cover the nursing staff, is that correct?
No,
It covers everything,
It
right?
covers
It's
It
really
covers
up to us how many deployments we want to have, and the order of these deployments will be decided by the respective departments.
I see. So the subscription cost covers however much we want
Correct.
to deploy. Okay, and then what kinds of contingencies would occur that might require the additional $3 million if it's a subscription-based service?
I mean, it could cover, any type of configurations that weren't planned. If we had a new union, with like a bargaining unit and had different rules. If
So it's
we
more
had
like
new,
implementation process.
pay scales, and throughout the period of the contract. So, if we had a period of COVID and we needed to set up, new codes,
I see.
and we didn't have that planned and we needed some help, that would be covered.
Okay,
If we opened up another hospital or a nursing home and we needed more staff, and it was a special title like T2, these are contingencies for things we can't even plan for.
right.
But we know that they can exist, so we'll build it into the contract, and hopefully we won't use it.
Okay, that makes sense. And obviously the cost reduction is really dramatic and a huge benefit as well. So I think this is just all around a terrific initiative. It is maybe difficult. I understand the difficulty in finding a good solution to meet the MWBE goals, but I think if we just stay focused with our partners and try to find ways to develop pipelines and capabilities. I think that is a very good effort. So, if there are no other questions or comments, I'll go ahead and poll each member for their vote. Jose,
Yes.
Mitch, Dr. Katz on. Okay, Sally?
Yes,
Sorry, yes, I couldn't find my unmute button. Sorry.
Thank you, Mitch. Sally?
yes,
And Dr. Marthone? Okay, oh, perfect, thank you. And I vote yes, so the motion is approved, or the resolution is approved to go to consideration by the board. Thank you, everyone. The next resolution we have is for outpatient coding and billing services. I believe Mr. Melican is going to read the resolution and start us off on the presentation. Is that correct?
Yes, thank you very much.
Thank you.
Resolution authorizing New York City Health and Hospitals Corporation, the system, to execute a 3-year contract with FICare Solutions, Inc., the contractor, for outpatient coding and billing services, with the system holding 2 one-year options for an amount across all potential 5 years of the proposed agreement not to exceed $12,491,383. So good morning. Thank you for having us here this morning. I'm Bob Melican, here with Ua Muan and Margie Carlin to present on the Revenue Cycle Services Coding and Billing RFP that we recently conducted. To frame this, where this sits within the Revenue Cycle Services, it's a unique place. H&H produces 2 types of claims. The professional, which is the bill for services performed directly by the provider, and it's billed completely separately. Professional claims follow a separate coding and billing rules. They work in a different module within our Epic services, our coding system. And H&H earns $32 million from professional billing. Very small compared to our institutional revenue, but very vital. The hospital claims are the institutional portion of the services, the regular bill that we're all familiar with. This includes the ambulatory surgery, outpatient, emergency room. H&H does the coding and billing for all of these services. But it's where we need assistance is with the high volume outpatient encounters that H&H does not have the internal capability to code at this point in time. So we'll be looking to outsource the outpatient coding services. In short, this contract is just for the coding and billing of professional claims and the coding of outpatient hospital claims. The vendor support for the professional portion is only at those hospitals where it's needed, where it's not a faculty practice. That is Bellevue, Kings, Queens, and Woodhull hospitals. Going to the next slide, we're replacing our we issued an RFP for a vendor that we currently have, and we released the RFP in May. And we had 2 components to this RFP. One was for coding, and the separate was for the professional billing. Each component had a separate committee and was scored separately. All of the submissions, except for one, were for both components. We received 7 proposals for coding and 6 for billing. We did an initial round of scoring to reduce that group down to 3, which we invited for formal presentations. We whittled that down again to 2 vendors for a 3rd round of Q&A. Both evaluation committees selected FICare Solutions as the highest scoring vendor. That's our current incumbent. Then in December, we moved to the Contract Review Committee to seek their approval for FICare, and we received that. So kind of want to turn it over to Ua at this point to run through just our RFP process.
So here's our RFP criteria and the minimum requirements. They must have an MWBE utilization plan or certification, 5 years experience, New York State Medicaid experience for coding and billing, and they need to have coding experience in Epic, and their annual revenue has to exceed above $25 million. And we were looking for large vendors that cover the New York State in our applicant pool. What takes priority for us is knowing that our vendor can handle, 1, our New York City Health and Hospitals, our coding requirements, and 2, they can handle a very large volume. And below is how we rated all the vendors who bid. So we rated them 40% cost, 30% quality of proposed operational approach, and 30% MWBE and quality assurance. And to the right, you see our evaluation committees for both the billing and the coding. It was made up of accounting directors, HM directors. We had a couple CFOs, EITS, compliance officer from each of the locations to the left. And we just wanted to make sure that the committee mirrored the folks that use Epic on a day-to-day basis and can ask the proposed vendors the much harder questions. The next slide. Okay, so right now we're making sure that FICARE meets all the MWBE requirements. They're in the process now of getting their certification with NYC Small Business Services. If their application is unsuccessful, then they will partner with two of the firms below, Qualcode Inc. for coding and billing responsibilities, and medical consultants to do the provider education, audits, and reviews. Their total utilization goal for both vendors is 30%. So Revenue Cycle Services, Bob and myself checked that they're both New York State official MWBE vendors. And the summary for the MWBE and non-MWBE responses that we got for this RFP are also below. Next slide. So what is our request? The Revenue Cycle Services seeks the Finance Committee's approval to award FICARE Solutions the contract for New York City Health and Hospitals coding and professional billing services. The contract that we're looking for is 3 years with 2 renewal options. For the chart below, you can see the estimated cost. The total cost for billing is $9.6 million, and the billing cost, the total comes out to $2.8 million. And that brings our total out to $12.49 million for the next 5 years. Any questions?
Thank you. I will go ahead and ask Dr. Pagan, any questions?
No questions, thank you.
Great. Dr. Katz?
I have no questions, but I wanted to take a minute of the committee's time to honor Margie Carlin and her revenue cycle staff. They have been real heroes over the last 3 years in building a revenue cycle. Really, health and hospitals had no revenue cycle work prior to that, and that their work, which is, isn't often noticed, is really what primarily was involved in eliminating the huge deficit that was threatening the future of health and hospitals and causing people to think we needed to close down facilities. This revenue cycle team has just been incredibly successful, and I think they deserve a huge amount of credit.
Thank you, Mitch. I completely agree and echo that. I was going to make the same comment, except I have one disagreement with you, which is that you said it's unnoticed. It's very, very, very much noticed here. So I think that is the only thing I would disagree with you on.
Well, I want to thank everybody. It's our team for sure, but we couldn't have done it without the partnership of everybody at the facilities, with the support of the executive teams and the facility executive teams, and of course the board. So thank you.
Thank you, Margie. Sally, questions or comments?
Just a couple. So we didn't use FICARE before. This is the first time that we're RFPing for this service?
They're our current incumbent right now. They're our current vendor right now. And then
Okay,
we
so-
did do an RFP
Right,
with the option of selecting a new vendor, and they did win.
okay. And the audit committee just approved an audit of our billing and coding functions. So are they going to be auditing the work that FICARE does? How do these come together?
So FICARE does our professional billing work, which is a very small portion of the overall work that we do. They also help us with our outpatient coding. Again, relatively small, high volume, but relatively small in the scheme of things of the entire revenue cycle process.
Mhm.
The RFP in front of the audit committee was really for some external eyes on the entire revenue cycle process, just to make sure that we're, crossing our Ts and dotting our Is and staying within our, compliance lanes. So
Okay,
they may choose to look at what FICARE is doing as well, but that
Mhm.
would be a relatively small component.
okay. And I noticed that the weighting for MWE was 20%, I think. Usually it's 10%, or,
I think we chose to do that because we had the room in the other criteria.
okay. And if it had been 10%, would it have affected the outcome?
No.
Good. Um, Okay, that's it. Thank you.
Great. Thank you, Sally. Dr. Marcone, don't know if her.
No, I'm fine. Thank you.
Okay, great. Thank you. And so I will go ahead and then ask each member for their vote. Jose,
Yes.
Mitch,
Yes,
Sally,
Yes,
Patricia? And I vote yes, so the resolution is approved. We will take it now to the full board. Thank you very much. And moving to our last resolution on ambulance services. Mr. Stiegler is going to read the resolution into the record and start us off on the presentation.
Sure. Thank you so much. I'm
Thank you.
pleased to be here with Caitlin Prescorn, who has led our transportation team so ably through all of our COVID surges. And here we're here today authorizing to request your approval, authorizing the New York City Health and Hospitals Corporation, the system, to increase the funding cap on the contract executed with Hunter Ambulance, which contract was assigned to American Medical Response of New York, LLC, as part of a corporate acquisition, the contractor, for a single vendor patient transportation system, such that the original spending cap of $12,070,896 to be increased to an amount not to exceed $21,837,906. So I'll hand it over to Caitlin to talk through our experience with Hunter to date and the next steps for our transportation system.
Thanks, Matt. So we signed the agreement with Hunter Ambulance in April of 2019, and the goal of this contract is really to simplify our inter-facility transfer process, bring in understanding of the data, understand all of our transportation utilization, and to be able to leverage the ambulance and ambulance services in case of a need. So obviously they were a huge component and support during the COVID surges. They helped us facilitate over 2,500 level loading transfers, allowing us to really balance the load across the system. So in the first year, we did notice that our spending was higher than anticipated, so we brought the approval for an increase to the not to exceed amount to the MNPA subcommittee in November of 2020. This was a result, our self-pay and uninsured trips were higher than expected. We added post-acute facilities onto the scope of work, and of course, unanticipated COVID-related expenses. So as you can see from the next slide, our transportation volumes have really gone up since the initial contract period in the beginning of 2020. The contract, the transportation volumes, as you can see, have gone up significantly in the first COVID surge, reflecting that maximal volume of level loading transfers, but have also increased in the subsequent surges. Where we sit today, we're projecting 9.7 million in expenses above our prior estimates. So this will cover our current spend and will also fund 1 year of operation to allow us to take a 1-year extension of this contract and evaluate options under a new RFP. So you can see on the graph on the bottom right, COVID expenses are in blue and reflect a really significant portion of the expense in fiscal year 20, and then additional expenses in FY21 and FY22, as well as projected in FY23. So this next graph demonstrates really the impact that this contract and all of the work that the teams at the facilities and our transfer working group have had to increase the volume of transfers within the system. So Comparing it to the 1-year period before this contract, our transfers have increased by 30% in 2021. So this is 1,400 new transfers that are within the H&H system and attribute to approximately 26 million in increased revenue. So we've also focused very closely with the AMR team, our Office of Quality and Safety, to improve our emergent interfacility transfer process, which is reflected in this data, but also highlights the ability to be able to integrate data between our Epic system, the CAD system, which is the dispatch system that Hunter uses to send trips to vehicles, building out protocols for our interfacility transfers, thinking about how do we streamline those protocols so that we can maximize the number of patients that are able to stay within the system and streamline that process. So most of our activity has focused on our major receiving facility, which is Bellevue, but also work significantly with Lincoln and Harlem as 2 large sending facilities in the system. On the MWBE front, there's 2 main scopes of work under this agreement. There's ambulance and there's ambulette transportation. At the time of contracting in April of 2019, AMR was granted a waiver due to the lack of availability and capacity of minority or women-owned businesses to perform these services. The remaining work that's not under ambulance or ambulette is self-performed by AMR's W-2 employees. So when you look at the breakdown, ambulance work is about 98% of our contract spend. Currently, there are no licensed MWBE ambulance vendors within the area, New York City area. Ambulette work is about 2% of the contract spend. There's limited availability and capacity of these vendors. So currently, AMR is contracted with 1 minority and women-owned ambulette vendor, Cathay. Our spend with Cathay represents 11% of the ambulette spend. There is an opportunity to contract with Leon's ambulette. Unfortunately, 2 of the other certified MWBE ambulette vendors in New York City have not responded to our request for information and contracting. So with Cathay and with Leon's ambulette, in partnership with the vendor diversity team and with AMR, we'll work together to build out the capacity of these vendors. So there'll be measurable outcomes. This will include KPIs, financial growth metrics. Initially, we'll be focused on increasing the volume of drivers that they have employed and increasing their geographic area. Most of these vendors are very concentrated in a specific area. So our goal will be to grow their ability to transport patients around the New York City metropolitan area. And we'll be looking at key metrics, number of trips, times to arrival, and driver counts. So we'll also connect them to resources offered by the City of New York. And by the end of 2022, we anticipate that 20% of the ambulette contract spend will be to these minority and women-owned ambulette vendors. So in terms of kind of next steps on transportation overall, our goal is to release a new transportation RFP this spring during this contract extension period. We've learned a lot in the last 3 years under this contract. This will allow us the chance to build out an emergency management scope in the case that we need to leverage dedicated resources for COVID transfers, for other emergent situations, build out integrations between a new vendor and Epic and our transfer center software, as well as building out new SLAs to reflect improved performance from these vendors. And finally, thinking about the MWBE, the ambulette capacity that we've been building and are building, and adding those commitments with a new vendor contract. And that is our request.
Great. Thank you very much for a very clear and comprehensive presentation. I will go ahead and ask for questions. Jose Pagan?
No questions, thank you.
Dr. Katz?
No questions, thank you.
Sally?
I have a couple of questions. Didn't Didn't we approve a contract to raise the rates from Medicaid to Medicare rates a year ago or something?
We didn't, but the contract was finalized at Medicare rates, which is part of higher rates than we initially projected.
Right,
So that is part of the reason for the not to exceed
yeah.
increase.
For some reason, I thought we approved that. It sounds like about $500,000 is the maximum that can be, at least at 30%, the maximum that can be set aside for minority ambulance services. Is that right?
Correct. We're estimating that 20% of that 436,000 will be able by the end of 2022 to go to our minority and women-owned ambulance vendors. So that's Cathay, which we currently contract with and are spending about 11% of that ambulance spend. And then as well as what we're anticipating, we will be able to grow with AMR throughout the next 9 months.
So how much can the two minority vendors that you have here, how much can they handle now?
So in current state, Cathay is currently working with Elmhurst and handling all of the Elmhurst volume, reflecting from both Medicaid, which is held separately than this, and what's called the bill facility, which is any of our self-pay or uninsured transports. And they're currently handling that very well. So our goal would be to increase that ability to potentially another location in Queens to work with them and build out the number of drivers that they're able to bring on board to be able to manage that volume additionally.
I'm a little confused. So you said it's 20% of the 436? Is that how much you said would be set aside?
That'll be the goal for by the end of 2022 to push
Is
it
that
up to that amount.
$80,000?
I'm sorry?
Is that 80,000? 20% of 436, is
Yeah,
that what
it
you're
would
saying?
be about $90,000, right?
That's to grow to 90,000. So their capacity must be very modest now. They're going to grow to 90,000.
Yes,
Not a lot of
currently,
money.
yes, currently it's about 11% of the ambulance spend, so it's $40,000-$50,000 right now.
Okay, and this transportation addition for livery, is that MWBE as well? I just see that you're going to launch new programs with livery transportation.
So that would be our goal, to look at MWBE vendors as a part of that. We never went through the process of incorporating livery under the AMR contract.
Right.
Because we were working with them on performance and we wanted their commitments on the ambulance minority and women-owned business. But when we look at livery programs, yes, that would be absolutely the goal when we're looking at potential vendors to contract with.
Okay, it sounds like you might have some luck with that. I just had a question about the new, that's okay. Thank you.
Okay, thank you, Sally. Dr. Marthone?
Yes, thank you. So fine.
No questions. Okay, great. Well, I want to just thank the team again. This contract has been very valuable, obviously, in getting us through COVID, as you explained, Caitlin, and balancing the load, and it's really helping us be a more unified system. So great work. I know it's been challenging times. I also do appreciate your efforts at trying to help create a solution to develop the capacity on WBE vendors. I think that's, as I mentioned before, very important. So as you guys continue to look for creative ways to do that, I commend you, so thank you. And again, the decision on what you're doing here to extend for 1 year while you prepare next steps and get a new RFP out, I think that's also very appropriate. So I did have one question on the I think it was the interfacility transfer volume slide. Caitlin, you referenced to $26 million in new revenue.
Yes.
Could you just explain that? Is that because we were able to keep the patient in H&H, and so that you're attributing the new revenue for that
Right.
purpose, where otherwise we may have had to transfer them out of the
Exactly.
system?
Yes. Yep, that's
Okay.
exactly correct.
Great. That's, again, just evidencing the importance of this. So thank you very much. If we don't have any other questions or comments, I'll go ahead and poll for a vote. Jose Pagan,
Yes.
Mitch,
Yes.
Sally,
Yes,
and Patricia.
Yes.
Great, thank you. I vote yes, so the resolution is approved and we'll take this to the board next week. I think that's it for our resolutions. Thank you very much. We're going to move on to an update now with John Alberg and the finance team.
Good afternoon. It's great to see everybody. Dr. Katz had made his presentation to the finance committee within City Council, which we thought, went very well. We reported, there is still tremendous volatility within the numbers. That's for certain. And James and Linda will go through in the very back here, the financial plan. And again, that's driven by COVID and our attempts to, restabilize the system, post-COVID. But overall, things we think look pretty good for us at this point, halfway through the year. We actually closed out January with $1 billion in the bank. That was quite remarkable for us. It must be pretty close to a historic all-time high. That was driven by the FEMA monies that we had received, plus the big dish payment, which came into us. That was short-lived, right? Because we had bills to pay. We rejoiced for a moment, but yes, there are certainly bills to pay, including, I think we paid back to the city $212 million in debt service. That was part of their budget the prior year. We're certainly happy to help out the city's finances where we can, and we did. And there were some, other obligations that we had to pay off. But 650 is a good place for us to be and still stable. At the mid-year point, we did miss the budget by $141.6 million. But when you look underneath those numbers, there's $388 million that we think is FEMA eligible related to COVID expenses. You net that out, you're at about $250 million to the good. And when you look into the numbers, that makes sense to us because you look into direct, patient care receipts, our year-to-year actuals, right? Those are actuals, not against the budget, is up $242 million. So the numbers all start making, sense to us. That trend line is quite phenomenal and it's sustaining itself, within rev cycle. That's an increase even over the prior year performance. Patient care volume is coming back, but we're still 4% below the Q2 FY20, which is our best. It's always been our benchmark. We keep a close eye on the financial initiatives. Through the halfway point in the year, about $400 million, and we have a line of sight, which is now increased to almost $680 million. So we feel pretty good at that halfway point, again, despite the volatility that exists within the financial plan. Next slide, James, do you want to do this one?
Yeah. I think, John, you pretty much covered this.
Yeah.
So I think we can keep going.
Managing the risks, right? We always keep our eye on the risks. The state city budget, right? We checked the green, right? I think, conversations are ongoing up in Albany, but everything there seems to indicate that it will be a positive budget for the healthcare system. And as a result, also for health and hospitals, we have a lot of strong advocacy going on, within Albany at the moment with Deb and Michelle. We're keeping a close eye on it, but nonetheless feel pretty good about that and the city. The next one's, right, future FEMA claims, right? We did receive our $620 million. We're anticipating another $161 million by the end of FY22 and more to come after that. So we really are keeping a strong focus on FEMA and generating, the paperwork that we need to submit, and the team has done, a fabulous job there, working on developing those packages. We're like the rest of the healthcare system, we're seeing wage pressures and inflationary costs. We're going to have to keep our eyes on that. And we continue to, develop our staffing models, right, to meet industry standards. Those will drive some additional costs that we're trying to make sure that we can accommodate those, into the plan for FY22 and 23. But nonetheless, it'll drive costs, but it's work that we need to do. So those are kind of the risks we see them at the moment. And then I'll turn it over, I think, Micheline. Turn it over to Micheline.
Sure. So for our performance through December, this is basically just a quick visual of what John went through in the highlights on the first page.
So I'll turn our attention maybe to the next couple of slides, which gets more into the mid-year performance drivers there. So on the revenue side, we continue, as John mentions, to bring in dollars and exceed our anticipated performance. So year over year, just looking at direct patient care and patient and outpatient, we have done better by 376 million. Our mid-year cash receipts against our budget are 10% or 410 million better. There is just a quick table at the bottom that sort of shows you where the buckets are that are contributing to that performance against our budget. Real high level, we have the increase in our volume. Basically, the volume on the inpatient side particularly was 9% better than we had planned to see compared to what we budgeted for. So we're yielding about 100 million better in year to date cash as a result of that. Similarly, our outpatient volume is also 7% better than we had planned, and even double of that in terms of percent better than where we were same time last year. We have higher collected rates across our patient care revenue. Again, that's attributed to the efforts done on the revenue cycle part and our strategic initiatives and the performance there. Risk performance is better than planned. There is a component that has a timing piece, but there is also a component of performance doing better than anticipated in there. And then finally, our revenue, other revenue, we have our 340B pharmacy and other pieces that appear better than we anticipated in our budget. The next slide, we get into what the drivers are on the disbursement side or the sort of cash out the door side. So our disbursements are over budget. We, again, don't budget for our COVID spend. So we have about 552 million, majority of that a result of COVID, where our cash out the door is higher than planned. 388 again out of that is for COVID emergency spend. This includes both staffing and non-staffing components. So our staffing components, majority of it lies in our temp agency in areas for nursing and credentialed providers. We will see more of that materializing also in the next quarter of the fiscal year as we see the impact of planning for Omicron. The vaccine mandate, we had to prepare for that. So you see that impact in the second quarter of the fiscal year. So we have to prepare for that in terms of coverage, both on the temp staffing side, but also our own staff overtime. When we adjust for COVID, we do see here an aspect where we are as a system getting out or rebounding from COVID. So now what we are trying to do basically is focus more on recruitment of our full-time and more stable staffing across the system and decommission our agency temp staffing, starting to move away from that and go back to our pre-COVID state where we focus more again on our full-time staff. So you're seeing some of that here. And our other discretionary spend, non-COVID, again, there's some adjustments there from a cash perspective, and some of our electronic payments, some of our larger vendors going EFT. So that's it for those pieces. Thanks. So for our next piece, we have the performance on some of our strategic initiatives. So we mentioned earlier some of the improvement against budget. John also mentioned our line of sight being, we're anticipating about 679 at the end of the fiscal year. So that's where you see that last column. Where are we through quarter two? We are at about 396 of that 679 million. You see greens all across. We have basically with the greens, we're either meeting or exceeding our anticipated target or expect to exceed our target by the end of the fiscal year. The one orange here is really more of, a variety of smaller initiatives that we believe it's kind of a timing again between like looking at a cash view there. So no concerns there. It's more of a timing. And again, it makes up for it and more in the other areas. So we have our growth and service line improvements. We have revenue cycle for our largest bucket, system efficiencies, and some of our value-based initiatives there, again, exceeding what we have planned for. We'll go to federal relief.
On the federal relief fund, just a quick update. So through January, we paid out about 2.6 billion total now on direct COVID expenses. We have commitments that may get up to 3.2 billion at this point based on purchase order and things that have been set up. That'll depend on.
I'm sorry, I
receipt
can't
volume.
hear.
Speak. Sorry, I can just repeat. So through January, 2.6 billion in total direct COVID expenses. We do have commitments that are up to 3.2 billion, which we could spend depending upon where the COVID volume and any future surge might be. In terms of reimbursement, as John noted early on, we did receive the 354 million that was long awaited in January, bringing our total FEMA reimbursement to $620 million. We do hope to get another $161 million by the end of the fiscal year, as John noted, potentially more beyond that. On the provider relief fund side, we still are at 1.2 billion, but we did receive 15 million, as we've talked about previously, from the phase 4, and that Micheline had noted. And at this point, we are working on submitting the required reporting for our PRF expenses through 12/31/21. So we're on track with that. We can go to the next slide.
Good afternoon. I'm Bob Melican again. Just doing an update. I think the board requested an update on denials performance and how we've been doing. And pleased to say we've been doing pretty well in the last couple of months. Really just to define what we're doing, a denial is really any communication from a payer, either that they're going to pay our claim in full or in part. And as you can see from the graph above, H&H had a very, very high denial rate coming out of our EPIC implementation in COVID. We started to clearly turn our attention to this problem at the end in January of 21. And we set a goal of ourselves of really achieving the EPIC median performance by the end of fiscal year 2022. Pleased to report that we hit that barrier. We met it in December of this fiscal year. And we're really now targeting to get to the EPIC top 25. These measures of median and top 25 are published by EPIC. They compare H&H across all EPIC users, and it's the industry standard that we're shooting for. To really kind of just show you where we had that cut, it's really across all categories of denial. We've bucketed them into the 6 top categories, going from January of 2021, well over 20% to into that 11% range now. And we've had reductions across all of the categories. And this isn't really just a revenue cycle initiative. We're getting a little bit of luck that we're sitting here in this seat because we've had a good deal of help from reimbursement, from managed care, from the Training Institute, and especially from all of the hospitals that contribute to the multitude of task forces that we do have. So it's really a full hospital effort across the board. HIM is in here. So really, we're just a little bit fortunate to be sitting here. So the big drop, as you can see, though, is in that claims configuration, and that's the technical configuration of a claim, making sure that what we're sending to a payer is proper in their format and that we're getting that communication back that it's okay. But across the board, we had that reduction. Next slide really is just, we're going to talk about timely filing. And Allison Smith will jump in on this. It's really a good example of our process, because at any point in the revenue cycle, from registration to the charging to coding to billing, a claim can get delayed. And really that handoff is what avoids a timely filing denial. Allison?
Hi, good afternoon, everybody. So I'm going to briefly define the timely filing denial. Every insurance company has a set time window in which providers can submit claims. And if a provider files claims later than that allowed time, they are denied for being past timely filing. To reduce these avoidable denials, we created teams that included subject matter experts from revenue cycle back and front end, HIM, managed care, revenue integrity, and facility management, as well as others. The groups identify root causes and present solution ideas for development to the overall team. Next, I will reference a small sample of some of the solutions that we implemented. So we did some system modifications. We built Logic and Epic that restricts the use of delay reason codes. A delay reason code is a New York State code that must be used on claims to allow late filed claims to bypass the allowed time limit for claim filing. So this logic was put in place to prevent timely claims from going across to New York State when they're not appropriate to go across. Secondly, we provided training. So through training with the collaboration of the Revenue Cycle Institute, we developed curriculum and trained over 300 users on timely filing guidelines and the appropriate use of delay reason codes on claims. We paired up with the managed care central office department to address claim issues on routine meetings with payers to prevent claim denials and claim delays. The process created is a continual monitoring and refinement of our implemented changes. We continue to test solutions to ensure we are achieving the desired results. If not, we refine. As you can see on the graphs to the right, our efforts, which included many other solutions, resulted in a 68% decrease in timely filing denials. Additionally, we want to highlight Bellevue as they are a top performer in this denial category.
Thank you.
Okay, so I'm going to give a quick financial update on Test and Trace, and then Dr. Long has joined us to talk through some of the recent programmatic announcements. If we just look at the chart here, we are projecting $1.7 billion in expenses for FY22. This includes our Omicron-related spending that we walked you all through in the January committee meeting. It does not include what Dr. Long will speak to in just a moment, but we'll go through those numbers in the next committee meeting. T2 committed about $385 million in expenses over Q2, and we are also continuing to receive sufficient revenue from the city through the MOU. So now I'll hand it over to Dr. Long.
All right. Hi, everybody. So I want to go over a couple of important, hi, Frida, programmatic changes that we've started to implement now based on where we've gone, the trajectory we've gone in during the pandemic, and also based on some updated CDC guidance.
Can't hear you, Ted.
So,
sorry.
Oh.
Whisper.
Very low
Can you hear me better now?
No.
You sound very far away. We can barely hear you.
Speaker, it's on.
Volume, hello.
He's very full
That happened to help.
It's playing in the other room.
Yeah, it's better. This is
You can.
It's us, Ted.
Okay, keep going. Sorry.
Okay. Can you hear me okay now?
Yes.
Okay. On February 28th, the CDC changed their recommendation around when to do contact tracing. This had been a change that we had been thinking about in terms of during the pandemic, when are we going to be at the point where we can transition into the next phase of really starting to learn to live with COVID. Two of the key things that we needed to achieve in order to transition into that phase was a high enough vaccination rate to make sure that our city was adequately protected, and to have medication so that there's a really clear recourse of what I do as a primary care doctor to help and oftentimes save my patients' lives if they should still contract COVID. We didn't have all of those things in place a matter of months ago, but in February, we got to the point where we did reach adequate levels of both of those criteria. And in acknowledging that, the CDC put out new guidance to no longer need to do universal contact tracing, which is where we were calling every single person with COVID across New York City, asking who they exposed, and then calling them in return as well. The data that supports that, by the way, is that cases had come down 99% from the Omicron peak. Approximately 97%, this is an incredible statistic, of New York City adults had received at least one dose of the vaccine. And there was adequate availability of sotrovimab and Paxlovid, both life-saving. Every time I prescribe it to 20 of my patients, one hospitalization will be averted, and they're widely available in New York City. When all of those things came together, we adopted the CDC's new guidance to have an end date of universal contact tracing at the end of April. To share a little bit about some of the high points of the last 2 years of doing this important work. Over the last 2 years, here in New York City, we've been able to reach more than 90% prior to Omicron of all new cases since June of 2020. We reached a much higher percentage of all new cases than any other city in the country. In doing that, we identified 1.7 million close contacts. We reached out to them, had an opportunity to notify them, to change their behavior, and to offer to help them with our New York City, unique New York City resources. One thing that worked really well too is, in addition to reaching out to those contacts, we helped more than 1 million cases or people struggling and suffering from COVID. So when we talked to you on the phone, it wasn't just who did you expose, it was who could you have exposed and how can we help you? And that's how we expanded our hotel program. We had a direct cash assistance program to allow people not have to make the false choice of going to work and potentially risking bringing the infection to work, or staying at home doing their right public health thing, but risking their family's livelihood. We were the only place I'm familiar with that had this sort of grants, at a scale of millions of dollars to help New Yorkers. So we're proud of the work that we've done. But April 30th of this year, we're going to make a transition. We're no longer going to call every case of COVID, but we are going to still text them. So in New York City, if you have a positive PCR or antigen test at one of our lab-based sites, we're still going to text you to let you know you have COVID. Here's your positive test. And we're building out now. We're going to have all this live before April 30th. Here's a link so you know exactly what that means for you. Whether you're a case with a positive test or whether you've been exposed and you want to go onto our website. You walk through based on your vaccination status, and we're going to give you precise, the boiled down CDC guidance exactly for what it means for you. We're also going to continue to offer to support you with our 212 COVID-19 hotline, which, by the way, you can call, press 9, get connected like that to one of Dr. Way's Express Care doctors, and get prescribed Paxlovid that can be delivered to you that same day. Really efficient system in New York City with all the learnings we've had about how important these sort of resources are for New Yorkers all the way through the pandemic. So we're going to keep our hotline going as well. And then just to make the point, we've had a very special relationship and opportunity with the Department of Health throughout. The Department of Health and us were in lockstep in developing our contact tracing program. My director of trace is Dr. Vora from the Department of Health for the first year of the program. So contact tracing is going to go back to the Department of Health now for high-risk settings, like congregate care settings, which they've done throughout. But any other further needs, like if there is an outbreak or any other further indication for contact tracing, the Department of Health, which helped us to build our program, will be using those same principles, that same approach from their vantage point on an as-needed basis moving forward. All right. I think that's it for me on the slide. I'm very happy to answer any questions.
Terrific. Thank you very much, Ted. Great review. And to the whole team, I think we'll just go through and see if anybody has any questions. Jose?
No questions, just impressed with everything that has been provided to us, and thank you for all the hard work on this.
Thank you. Sally?
It's more of a comment. Well, first, congratulations, Ted, on the amazing work you continue to do.
Thank you.
We built some amazing relationships with nonprofits. through this, through T2. And I think there should be some way to kind of memorialize and have them available as a resource. Not start searches de novo, because these are groups that you know you can count on, that's been able to deliver under the most stringent of circumstances. So how that gets captured, I don't know, but I think that's an important thing to do. And in addition, the relationships you built with the educational system in New York. That those are long-term relationships that have been established, and it would just be a shame to kind of, walk away from them.
Yeah, Sally, great points. I'll be very brief. This is an area I'm very passionate about. But we've been funding over 30 community-based organizations that we actually just announced yesterday we're going to continue funding through the rest of this fiscal year 4. Thank you to OMB for allowing us to have that funding. But those relationships were also transitioning to the Department of Health for more longitudinal, addressing COVID and the disparities that COVID has really brought out across our city and exposed. But in addition to that, our home tests are going to be a very important thing moving forward to help us to learn to live with COVID. So that if you start to feel symptoms at home, you do a home test, and then you wouldn't go to work that day, and you'll immediately know your status. We actually created relationships now based on what you just said, Sally, with more than 650 community-based organizations and houses of worship across New York City that are the trusted messengers of all of our communities. And we've started to do this, and we're going to continue to do this. From the testing standpoint of test and trace, arm them with as many home tests as they need to make sure that we're getting home tests to everybody across New York City without exception. And it's all built on the foundation that you were just describing. So that work won't end. In fact, it's going to increase.
Thank you, Ted.
Great. Thank you. Patricia, any questions or comments?
No, none. Thank you.
Thank you. Okay, well, I just want to say again to the entire finance team and Ted also, just incredible work, and thank you for the update. The denial update was really terrific. Continuing the revenue cycle work, and clearly we have some significant risks and challenges as John outlined, but the focus on all our strategic initiatives and everything is just terrific in keeping us on track to try to manage through those. I think we have one other item on the agenda. I know we're running short on time, but I do want to ask James to just briefly talk about the January financial plan.
Sure, I can go through it very quickly, and we can go to the next slide with the talking points. So this is really just giving a very high-level picture of our total revenues and expenses for the FY22 through FY26 financial plan. This was released earlier this month in conjunction with the city. We always work closely with OMB to get this out, and as John noted, it was part of the preliminary budget hearing yesterday at the city council. In terms of what we're looking at over the years, you will see that we do have a small negative operating margin of about $80 million this year. As John noted, this is a plan that's on a cash basis, and so that in large part is due to the timing of receipts from FEMA. So we have costs for COVID that are happening this year. We don't expect to get the revenues until further down the line. And you can actually see that flips when you look at our operating margins for fiscal year 23 and 24. We're currently showing a positive $22 million in FY23 and a positive $91 million in FY24, which we expect to have, assuming that we catch up fully on the FEMA receipts by that point. As we, look also at our cash during these years, which is important, we started at a strong place this year. And so for each of the next 3 years, we do expect to end somewhere between 650 and 675 million per year, which is about 30 to 35 days cash on hand, which is a stable position for us in a place that we would certainly like to be throughout. Finally, I think as we just look towards our strategic initiatives and towards the later years at the dish cuts returning, which happens beginning in FY24, we do see in fiscal year 25 and 26 that we do have some deficits to manage. However, those dish cuts have been delayed 5 times before now since they were first going to be implemented in 2014, and so we are hopeful that they can be pushed back again. We would in fact continue to be break even if we would adjust for the strategic initiatives that we increase in those years, and so we feel positive that we can continue that advocacy as we have in the past, that we continue to be in a stable position. And finally, just an overall note about the plan itself, as may have been evident from previous comments, but we do assume in this plan that we are made whole for our COVID expenses through a combination of patient care revenue, provider relief funds, or FEMA funds, over the life cycle. So that's an important assumption that just runs through all of this. John or Linda, anything to add?
John?
No, I'm good.
Great. Thank you very much for running through that. I'll just see if anybody has any questions. Jose,
No questions, thank you.
Sally?
Quick question. I noticed your OTPS expenses dropped by 50% between projected 22 and projected 23. Is that just an amalgam of things?
Yeah, so the really the large majority of that is our COVID and T2 spend largely exists in there. So we have major COVID and T2 expenses that are in fiscal year 22. We do expect some additional costs to occur in fiscal year 23. And then really at FY 24 and out would be our normal non-COVID baseline. In addition, in FY 22, it is slightly higher because some of the payment rolls or things like that, as John noted, like the debt service payment that we had made, that was rolled from FY 21 to FY 22.
Okay, thank you.
Thank you, Sally. Dr. Martone?
No, I'm fine, thank you.
Great, thank you. James, just one quick question on the last point you made, being made whole on the COVID expenses. Does that mean, for example, so right now I think we're at somewhere in the neighborhood of 1.8 to, with the current request in for FEMA, maybe close to 2 billion in terms of FEMA plus provider relief funds. But I think we've spent 2.6 and committed maybe 3.2. Is the expectation we would be able to fill that full amount, even if we were up to 3.2 from FEMA or other federal dollars?
That is the expectation, yes. I mean, I think we will continue to see what spending we have and determine, what to submit to FEMA. But we are hopeful that everything that we have spent to date, and if there are additional costs, that FEMA would cover it, assuming that we don't have another source of revenue to do so. Okay.
Thank you for pointing that out. All right, great. Thank you very much for a wonderful today presentations. Is there any old business to come before the committee? Any new business? If not, then adjourned.
Thank you.
Thank you, everyone. Be well. Sure. Happy to. Yeah.
Thanks, everyone.
Oh, I'm glad you got through it.
We got through it all. I got through it.
Good job, Sally.
Yes.
You got us through the whole thing. How you doing?
Good,
There's
I'm
gonna be
good.
some questions that come up, and I think it's important
Yeah,
to
you
share.
got
but
through.
if we
I think
can
that's
do
the
this-
first. I think that's the first.
I thought it was
that we've gone
absolutely,
through
we were taking
everything.
bets whether we're gonna do it, get through it all.